All right, let's dive right into something that's becoming, well, a major challenge in orthopedics, especially with more and more people living longer, having active lives. We're talking about fractures around existing hip replacements. Now, these aren't your typical broken bones. They present a unique sort of puzzle for us in the medical field.
They really do.
And the global rise in these periprosthetic hip fractures, it's directly linked to the incredible success and just the sheer volume of total hip arthroplasties, THAs, being performed worldwide.
Hmm.
What's also quite fascinating is that we're seeing THAs not just in the elderly, but increasingly in younger, more active individuals. And that naturally broadens the spectrum of potential complications, and it challenges us to adapt, doesn't it?
Absolutely. It changes the game somewhat.
And beyond the immediate clinical complexity for the patient, there's also a significant economic impact these injuries have on healthcare systems. It's not insignificant.
Not at all.
Today, we have Professor Mo Imam with us, an expert guide who will help us navigate this, well, intricate and evolving area. Our mission for this deep dive is to give you, our listener, a comprehensive, up-to-date understanding of how these fractures are managed right from the moment they're diagnosed through to rehabilitation.
It's truly a compelling area because, these fractures represent a critical crossroads. It's trauma surgery meeting arthroplasty. They demand a very specific combined skill set from orthopedic surgeons, often pushing the boundaries of our expertise.
Right.
And their effective management isn't just about technical surgical skill. It truly requires seamless multidisciplinary input to achieve the best, most lasting outcomes for the patient. This isn't a problem one specialist can solve alone.
That immediately highlights just how multifaceted this challenge is. So let's begin by trying to understand the sheer scale of the issue. Just how common are these periprosthetic fractures? And what are the main factors putting patients at such a heightened risk? Could you give us a sense of the incidence and maybe the typical mechanisms of injury we're seeing?
Certainly. Periprosthetic fractures around the hip, they can occur during two distinct periods, either intraoperatively so, right there on the operating table during the surgery itself,
Okay.
or postoperatively, which is, after the procedure's been completed. Now, looking at intraoperative fractures, they are notably more common in unsuspended total hip arthroplasties. We're talking about roughly 5.4% of cases,
5.4%, okay.
which stands in stark contrast to cemented THAs, where the incidence is much lower, maybe around 0.3%.
Big difference.
Huge difference. And what's particularly striking is that this risk escalates significantly during revision surgery. It jumps to an alarming 20.9%,
Wow, 20%.
compared to a primary arthroplasty where it's about 3.6%.
Yeah.
Now, this tells us something profound about the perhaps compromised bone quality or the altered anatomy we often encounter in those revision cases.
Right, the underlying bone isn't pristine anymore.
Exactly. Then, postoperatively, the incidence of periprosthetic femoral fractures is less than 1% after a primary THA, which sounds low. But it can rise to as much as 4% following revision surgery. So that indicates a kind of cumulative risk over time. The overall lifetime risk after any THA is estimated somewhere between 0.4% and 3.5%. And it's crucial to understand their significance in the bigger picture. These fractures are the third most common reason overall for THA revision.
Third most common.
Yes. And interestingly, they climb to become the second most common reason beyond the fourth year post-primary THA. That's a trend consistently observed in large national data sets, like the Swedish National Hip Arthroplasty Register, which gives us invaluable long-term data.
That long-term perspective is key.
It is. And while periprosthetic femoral fractures are overwhelmingly the most common type we discuss, it's worth remembering that acetabular fractures affecting the hip socket can also occur.
Ah, yes.
These are much rarer, making up only about 1/10 of all THA-related fractures. And they predominantly happen intraoperatively, often due to the force involved in implanting a new cup.
Right, getting that cup seated.
Precisely. As for the mechanism of injury for the postoperative fractures, the vast majority, around 86%, result from surprisingly low-energy trauma.
86%. Low energy.
Yes. We're talking about simple falls from standing height. This isn't about high-impact car accidents in healthy individuals. It speaks volumes about the fragility and often the comorbidities present in this patient demographic.
I find that fascinating, that these low-energy falls account for such a high percentage. It almost feels counterintuitive. You'd expect high-impact trauma, but it's often the simple trip that causes the catastrophic failure, isn't it?
That's precisely the point. It's often not a major external force, but an underlying systemic vulnerability.
Right. So given that, what are the key patient-related risk factors that truly contribute to this underlying vulnerability?
Well, several patient characteristics consistently contribute to an increased risk. Female gender and advanced age are frequently cited, largely due to age-related bone density loss and higher rates of osteoporosis. However, it's worth noting that while these are common associations, the evidence across the literature can sometimes be a bit inconsistent on their independent impact.
Ah, okay. Nuance there.
Exactly. But what is consistently identified are certain underlying medical conditions. Osteoporosis, of course, is a significant one, but also rheumatoid arthritis, Paget's disease, and developmental hip dysplasia, all of which compromise bone quality and integrity. Crucially, an increased time from the initial arthroplasty procedure is also a significant factor. As implants age, bone remodels and bone quality can naturally deteriorate over decades.
So the longer you have the hip replacement, the higher the risk, potentially.
Potentially, yes, the cumulative risk increases. Beyond these specific diagnoses, age-linked comorbidities, particularly osteoporosis and cognitive decline, pose substantial and compounding challenges. Osteoporosis, as you might expect, doesn't just make fractures more likely, it also makes them significantly harder to stabilize once they occur. The bone itself just lacks the structural integrity for screws or plates to hold securely.
Right, fixation becomes a real issue.
A major issue. And cognitive decline, on the other hand, creates this cascade of risks. It impairs a patient's judgment and balance, making falls more frequent. But it also profoundly impacts their ability to understand and comply with the complex post-surgical regimens, things like weight-bearing restrictions or specific movements, which are absolutely vital for successful recovery and preventing further complications. It's a truly holistic risk picture, you see.
It sounds like a deeply intertwined web of patient health and, as you touched upon, the implant itself. On that note, what about the implant design and the surgical technique itself? How do those contribute to the risk profile? Are there certain choices or technical considerations that increase or decrease the likelihood of these fractures?
Indeed, implant design and the meticulousness of surgical technique play a profound role. Several key factors here are well established. Stem malposition during the initial surgery, for instance.
Ah, placement.
Exactly. Where the femoral stem isn't aligned perfectly, that can create stress risers in the bone, making it more prone to fracture. Pre-existing osteolysis, that's bone loss, due to wear particles from the implant or aseptic loosening of the implant, means the bone around the prosthesis is already compromised before any trauma occurs.
Right, it's weakened.
It's weakened already. And the patient's surgical history specifically, the number of previous surgeries to the same region also increases risk, often due to altered anatomy, scarring, and reduced blood supply. Now, when we delve into implant types, cementless femoral implants have been consistently associated with a higher incidence of periprosthetic fractures, both during the surgery itself and in the postoperative period.
Okay, cementless specifically.
Yes. For example, studies have indicated that intraoperative fractures occur up to 14 times more often with uncemented components.
14 times. Wow.
It's significant. And this risk is particularly pronounced in female patients over 65 years old who receive uncemented components, highlighting a specific vulnerable subgroup. While post-operative fractures are also more common with uncemented implants, interestingly, this seems to be independent of age and gender.
Interesting.
Specific implant designs also matter significantly. There's been a notable threefold increase in periprosthetic fracture rates observed with single wedge and double wedge implants when compared to anatomical, fully coated, or tapered-routed components.
For shape matters.
The shape and how it engages the bone absolutely matters. The difference lies in how these stems engage with the bone and distribute stress. For cemented implants, Exeter type, or force-closed stems, which are designed to subside slightly into the cement mantle, creating stability through a wedge effect. They tend to show a higher risk of periprosthetic fracture than Charnley type or composite beam stems. Charnley type aim for more rigid fixation and distribute stress differently along the bone-cement interface. It's a fundamental difference in biomechanical philosophy that directly impacts how the implant interacts with the bone, and consequently its susceptibility to fracture.
That makes sense.
And lastly, periprosthetic acetabular fractures are typically linked to uncemented press-fit elliptical cups, again due to the mechanics of their initial fixation. So yes, the choice of implant, its precise placement, and its inherent biomechanical properties are absolutely paramount.
That level of detail on implant mechanics is crucial. Now, once a fracture is suspected, the initial assessment is, as you said, absolutely critical. What's involved in thoroughly evaluating these cases? And how do classification systems guide your decision-making, especially considering the challenges you mentioned in preoperative stability confirmation?
Right, the initial clinical and radiological assessment is the absolute cornerstone of managing these complex cases. It always begins with a detailed clinical history and a thorough examination. Most patients present following a low-energy trauma, so establishing that clear context is vital. However, it's equally crucial to dig deeper and ascertain if there were any pre-existing worsening symptoms before the acute injury.
Ah, like warning signs.
Exactly. Things like persistent thigh pain, the notorious startup pain, or groin pain. These could be subtle indicators of an already loose or failing prosthesis, which would fundamentally alter your management strategy.
Okay.
A critical, often overlooked step is actively ruling out infection. Periprosthetic joint infection, or PJI. It's been reported in about 11.6% of periprosthetic fractures.
11%, that's quite high.
It is, and it can be devastating. However, a significant challenge is that standard inflammatory markers like white cell count, ESR, and CRP, while helpful, have been shown to have, well, poor predictive value for deep PJI.
So they aren't reliable enough on their own.
Not always, no. If clinical suspicion for PJI is low, we typically proceed with surgery, taking multiple intraoperative tissue samples for culture and histology to confirm. But if there's a high clinical suspicion based on the patient's history or exam, preoperative aspiration and biopsies are strongly recommended to guide subsequent antibiotic and surgical planning. You need that information up front.
Makes sense.
Radiological imaging is, of course, vital. Full-length X-rays of the entire femur, extending from the hip to the knee, and a comprehensive pelvis view are essential. These allow us to determine the fracture's precise location, its characteristics, is it spiral, transverse, comminuted, and crucially, to assess the prosthesis' stability and, for cemented components, the integrity of the cement mantle. It's also incredibly helpful to retrieve all previous imaging, if available. A patient's radiological history can often reveal subtle signs of component migration or pre-existing osteolysis, guiding us to potential weak spots.
Looking for changes over time.
Exactly. A CT scan is also standard practice now. It provides more detailed information on bone stock, the exact fracture pattern in 3 dimensions, and the integrity and stability of the components, especially around the stem. Now, regarding the challenge of preoperative THA stability confirmation, you hit on a key point. There's a reported 20% discrepancy between what we think we see on preoperative imaging and what we actually find intraoperatively.
20%, that's a big gap.
It's a significant gap. Indirect methods, such as assessing distal implant translation or using fluoroscopy in the clinic, are often inconclusive if they are negative. Ultimately, the most reliable method remains the hands-on intraoperative assessment during surgical exploration.
So you really only know for sure once you're in there.
Pretty much. This 20% discrepancy isn't just a number. It fundamentally shifts how surgeons must approach these cases. It forces an extraordinary level of intraoperative adaptability, a true test of surgical intuition, beyond what any scan can tell you beforehand. It highlights the art as much as the science of orthopedics. This is why thorough planning with clear contingency strategies is absolutely crucial. You have to be ready for Plan B or even Plan C.
That 20% unknown is enough to keep any surgeon up at night, isn't it? So once you have that comprehensive assessment, understanding these nuances, how do classification systems like the Vancouver system help guide precise management decisions, especially given those diagnostic challenges you highlighted?
Indeed, it emphasizes the need for surgical readiness. Classification systems are absolutely fundamental to guiding management. They provide a common language and a framework. The Vancouver classification system remains by far the most widely used and accepted system for femoral periprosthetic fractures. It's rather elegant in its simplicity, categorizing fractures based on 3 key parameters: the precise location of the fracture relative to the implant, the stability of the implant itself, and the quality of the surrounding bone.
Okay, location, stability, bone quality.
Precisely. To quickly summarize its main types, AG describes fractures of the greater trochanter, AL for the lesser trochanter. Then we move into the more complex B types, which are around the stem. B1 indicates a fracture where the implant is stable. B2 means the implant is unstable. And B3 signifies an unstable implant combined with poor, deficient bone stock.
Okay, B1 stable, B2 unstable, B3 unstable, plus bad bone.
You've got it. Finally, type C fractures occur well below the stem tip. However, despite its widespread utility, the Vancouver classification has its limitations. A significant finding from a Swedish study, for instance, revealed only a 34% agreement between surgeon and radiologist classifications for B1 fractures.
Only 34% agreement. That's low.
It is surprisingly low,
Yeah.
and it dramatically highlights the real challenge in accurately differentiating a B1 from a B2 based solely on radiographs before surgery. This again underscores why intraoperative assessment of stem stability through direct palpation and manipulation is absolutely paramount to confirm the classification and therefore guide the definitive treatment.
So the X-ray gives you a clue, but the final decision is made in theater.
Essentially, yes. Beyond Vancouver, the Unified Classification System, or UCS, is a newer, more comprehensive system. It's designed to classify all periprosthetic fractures, regardless of their anatomical site, so not just the hip. It's shown strong intra-observer agreement for experienced orthopedic surgeons, around 0.920, which is good, but notably lower for residents at 0.772, indicating there's a learning curve.
Right. It's a broader role in everyday clinical decision-making versus research is still being thoroughly evaluated. We also have other, more specific systems, such as the Periprosthetic system and Pasquarella et al.'s method, tailored specifically for periprosthetic acetabular fractures. These systems provide a vital framework, but as you rightly pointed out, profound clinical judgment, continuously informed by intraoperative findings, is always the ultimate guide.
So we've nailed down how to classify these fractures, but the real challenge, the art of orthopedics, begins now.
Yeah.
Choosing the right weapon for the right battle. Because as you've highlighted, a Vancouver B3 is a world away from an AG fracture. How do you even begin to tailor a strategy when there's no true one-size-fits-all for such varied injuries? What are those fundamental principles guiding your approach to optimal management? You've perfectly articulated the core dilemma. There's simply no cookbook for these cases. A highly individualized approach is utterly essential. Treatment decisions must carefully consider a whole constellation of factors. The patient's existing comorbidities. Are they diabetic? Do they have cardiac issues? What were their functional levels before the fracture? What's the confirmed stability of the implant? And critically, what are the available resources and surgical expertise?
That last point is important, isn't it? Not every hospital has the same kit or experience.
Precisely. Not every center has the same level of specialized equipment or surgeon experience with complex revisions. And not infrequently, multidisciplinary input is critical, often involving geriatricians, infectious disease specialists, or intensivists. There's a growing recognition of the need for focused clinical pathways for periprosthetic fractures, mirroring what we've successfully implemented for other fragility fractures like native hip fractures.
Like the neck of femur pathways.
Yes, exactly. This signifies a systemic evolution in how we approach comprehensive care, moving beyond just the immediate surgical fix to a more holistic, standardized patient journey. Historically, non-operative treatment of periprosthetic fractures has generally been associated with pretty dismal outcomes. We're talking non-unions, malunions, and significantly increased medical complications.
Right.
This is why operative intervention is now overwhelmingly the contemporary choice for almost all cases. The only real exceptions are critically ill patients who simply cannot physiologically withstand major surgery. However, it's worth noting some newer emerging evidence on anabolic drug therapies like teriparatide combined with specific non-operative protocols. Even for very minimally displaced B2 fractures, this could potentially offer an alternative for extremely frail patients who are otherwise inoperable. Still early days, perhaps.
Interesting potential development there.
It is. Once surgical treatment is decided, several fundamental principles come into play. Meticulous preoperative planning is paramount. And this isn't just a cursory glance at X-rays. It involves detailed revision templating, virtually placing implants on images to plan size and position, and verifying that all appropriate surgical kits, including revision instruments and possible backup implants, are physically available in the hospital.
Checking the kit beforehand is vital.
Absolutely. The surgical approach must be chosen carefully to minimize soft tissue damage, preserving the critical blood supply to the bone. And, given the potential for unexpected findings, particularly with that 20% discrepancy we discussed, having robust backup plans for different scenarios is always essential. This truly highlights the necessity of having combined advanced trauma and arthroplasty skills within the operating team.
You need both skill sets.
You really do. The overarching aim of the procedure is always consistent. Restore anatomical alignment with a stable implant, preserve existing bone stock wherever possible, promote predictable fracture union, and, crucially, enable early patient mobilization and preservation of joint motion. The specific choice of implant and technique is then ultimately guided by the fracture's precise location and complexity, the prosthesis's confirmed stability, and the quantity and quality of remaining bone stock, all balanced against individual patient factors like their physiology, bone healing potential, and any existing comorbidities.
That's a remarkably comprehensive framework. Let's talk specifics now, starting with Vancouver type A fractures, which involve the proximal trochanteric region. How are these typically managed, and what are the nuances for each subtype?
Right, Vancouver type A fractures are typically the least complex. They involve either the greater trochanter, classified as AG, or the lesser trochanter, AL. For AG fractures involving the greater trochanter, these are generally considered stable fractures. They're very often managed non-operatively.
So no surgery usually.
Often not. Just a period of protected weight-bearing and restricted active hip abduction for approximately 6 to 12 weeks. This allows the trochanter to heal in place. However, surgical fixation, using simple techniques like wires, cables, or small specialized plates, becomes indicated if there's a symptomatic non-union, meaning persistent pain, or functional issues like limping or weakness.
Okay.
Or if there's significant migration of the trochanter fragment, typically defined as more than 2 centimeters displacement.
Sure.
And if the fracture is also associated with particle-induced osteolysis, which is that bone loss due to wear particles, the underlying osteolysis must also be addressed.
Right, tackle the root cause.
Exactly. Depending on the extent of bone loss and the stability of the main implant, this might range from a simple bearing surface exchange with bone grafting to a full acetabular and femoral stem revision. As for AL fractures, affecting the lesser trochanter, these are usually treated non-operatively, similar to undisplaced AG fractures.
Also non-op usually.
Yes, the rationale here is that the lesser trochanter is often not critical for hip stability. Surgical intervention is typically only considered if the fracture is unusually large and extends into the calcar region of the femur, potentially compromising the stability of the main stem. In such rarer cases, circlage wiring, where wires are wrapped around the bone to provide compression with or without grafting, or even stem revision with diaphyseal fixation, may be necessary. If an AL fracture occurs and is identified intraoperatively, which is common due to instrument placement, circlage wiring is usually advised immediately to prevent displacement, followed by a period of protected weight-bearing post-surgery.
So, relatively less invasive approaches for type A fractures unless there are those specific complicating factors. Now, let's move to Vancouver type B fractures, which you noted are arguably the most challenging category and certainly the most prevalent. How do you approach these? Starting with B1, where the prosthesis is stable but the bone around it is fractured.
Yes, type B fractures truly represent the bulk of the challenge. They account for the vast majority, with B1 at maybe 29% and B2 at 53% in some large registries like the Swedish Hip Arthroplasty Register.
So B2 is the most common overall.
It often appears to be, yes. The difficulty often lies in accurately determining the prosthesis' stability and the bone stock quality, even intraoperatively. For subtype B1 fractures, which occur around a stable prosthesis, the conventional approach is indeed open reduction and internal fixation, or RIF, primarily using extramedullary devices such as plates and circlage cables.
Fixing it with plates and wires.
That's the traditional idea. However, this approach comes with significant inherent challenges. These extramedullary implants are off-axis load-bearing devices. This means they are exposed to incredibly high bending stresses, particularly when the patient begins weight-bearing.
Ah, the physics work against you.
They do. Combined with the typically slow bone healing process in elderly patients who often have osteoporotic bone, this can frequently lead to early fatigue failure of the plating system before bony union is achieved. The very nature of osteopenic or osteoporotic bone, coupled with the existing stiff implant or cement mantle, severely complicates screw anchoring and fixation. It substantially increases the risk of mechanical failure.
The screws just don't hold well enough.
Exactly. There's also the potential for the existing cement mantle to fracture during screw insertion and a negative impact on the already compromised intramedullary blood supply due to prior reaming or the exothermic reactions of cement. So, to address these issues, modern techniques often favor bridging locking plates. These plates act as strong extramedullary bridging splints, creating a fixed-angle construct that is ideal for osteopenic bone.
Locking plates, how do they help?
Well, they are considered more biologically friendly because they don't rely on plate-to-cortex friction or precise screw thread purchase for stability. They lock into the plate, providing angular stability. This preserves the crucial periosteal blood supply. Contemporary plates feature anatomical designs, variable interlocking options that allow surgeons to navigate around the existing stem, extensions for trochanteric fragments, and multi-directional screw placement to target available healthier bone. These can often be applied using minimally invasive plate osteosynthesis or MIPO techniques.
MIPO, so smaller incisions.
Yes, further reducing soft tissue damage and preserving that vital blood supply. Studies consistently show excellent union rates and reduce complications with MIPO compared to traditional open approaches for B1s. Crucially, though, surgical parameters must be meticulously observed. Plate working length. That's essentially how much of the plate bridges the fracture should ideally be 2 to 3 times the width of the femur at the fracture level. Too short, and you concentrate stress. Too long, and you might unnecessarily stiffen the bone, risking a fracture at the plate ends. Similarly, plate span width for comminuted fractures dictates the length of the plate relative to the shattered bone segment, typically 2 to 3 times the fracture length. And critically, plate screw density, aiming for less than 0.5, means strategically spacing your screws to distribute load evenly and prevent stress risers that could lead to early fatigue failure, especially in compromised bone. Spreading the load. Precisely. While bicortical fixation is biomechanically superior, if not possible, a combination of circlish wires or cables for bending resistance, combined with unicortical locking screws for torsion and axial compression, can be used. And a key rationale today is to use long plates that span the whole femur, sometimes even the entire diaphysis.
Protecting the whole bone.
Yes, to protect against future injuries, as these patients are unfortunately prone to subsequent falls and new stress risers.
So, MIPO and advanced locking plates are truly changing the game for B1 fractures, allowing for more biologically friendly and robust fixation. But you mentioned a fascinating paradigm shift, even within B1, where revision might be preferred over fixation despite a stable prosthesis. That's truly counterintuitive. What's the biggest hurdle for surgeons in making that shift away from simply fixing a B1? And in what specific scenarios does this alternative approach become the superior choice?
That's a really insightful question, and it gets to the heart of evolving surgical philosophy. The biggest hurdle is often the initial inclination to preserve an apparently stable, well-integrated femoral stem. You think, well, why dismantle something that appears to be working?
Exactly. Seems like more surgery.
It is more surgery initially. However, for some particularly challenging B1 fractures, revision arthroplasty with a long stem, essentially acting as an intramedullary splint, can genuinely be a more effective and durable strategy. This is especially true for short, oblique, or transverse B1 fractures located precisely at the stem tip, or very comminuted fractures right there.
The really awkward ones at the tip.
Precisely. With an extramedullary plate alone, the construct remains an off-axis load-bearing system. Achieving optimal biomechanical strain at the fracture site, especially where stress transitions acutely from the very stiff proximal segment, which includes the well-fixed existing stem and the proximal part of the plate, to the distal femoral fragment, can be exceedingly difficult. This often leads to delayed healing, non-union, or plate fatigue failure, requiring further surgery down the line.
So the plate fix might fail eventually.
It has a higher risk of failing in those specific scenarios. In these challenging B1 cases, the decision shifts towards a more pragmatic approach. While it means a greater initial surgical intervention by revising an otherwise stable femoral stem, this is often counterbalanced by the biomechanically advantageous in-axis load sharing provided by the new, longer femoral stem. This revised stem should extend well beyond the fracture, bypassing the fracture level by at least 2 cortical diameters, ideally more, to act as a strong internal splint.
Using the new stem as the fixation.
Exactly. Essentially, for these challenging B1s, the decision shifts from a technically simpler fix to a patient-specific strategy that prioritizes overall long-term survival, earlier and safer mobilization, and a more uneventful postoperative course. It reduces the likelihood of repeat surgery. It's about looking beyond the immediate fracture and considering the entire biomechanical system and the patient's overall journey.
That's a profound strategic shift. Now, if B1s can be this complex, what happens when you're dealing with an unstable prosthesis, as in subtype B2, but you still have decent bone stock? How does that shift the treatment paradigm?
Right, for subtype B2 fractures where the prosthesis is confirmed to be unstable but the surrounding bone stock is still adequate, the consensus approach is generally a long stem revision arthroplasty.
Revision is the main plan here.
Yes, generally. This is often supplemented by additional plate fixation and/or allograft strut fixation to help consolidate the fracture. Evidence strongly supports this. Systematic reviews and data from national registries, such as the SAR again, consistently show significantly higher reoperation rates for B2 fractures treated with ORIF alone, around 32% compared to a much lower 10% for those treated with revision surgery.
Big difference in reoperation rates.
Huge. This is because fixing the fracture without addressing the underlying unstable implant is often doomed to failure. The loose stem will just continue to move and prevent healing. In these revision surgeries, the choice of stem is crucial. Long, porous-coated cementless stems or tapered fluted modular titanium, known as TFMT stems, are very commonly used due to their excellent distal fixation capabilities in the healthier bone further down.
Getting fixation distally.
Exactly. For very frail or unreliable patients, or those with more distal fracture extension and poorer bone stock distally, cemented stems can also be considered. They offer immediate stability for early weight bearing, which can be critical in that group. And as with B1 fractures requiring revision, the new stem should bypass the most distal fracture line by at least 2 cortical femoral diameters to provide sufficient stability and protection against refracture. Now, there's an interesting and unique nuance for periprosthetic fractures that occur around cemented, polished, tapered stems, which are common implants like the Exeter stem.
Ah, the tapered ones.
Yes. Due to their design principle, they are forced closed and rely on controlled subsidence into the cement mantle. These stems are, by their very nature, inherently unstable when a fracture occurs around them. So while revision with a new long stem is still considered the gold standard, or IFF alone can sometimes be a viable option if the fracture is reducible and the existing cement mantle is well fixed to the bone.
So fixing the bone might be enough if the cement is solid.
Potentially, in selected cases. This approach can be less demanding surgically, quicker, and potentially involve less blood loss, which can be advantageous for very sick or elderly patients. Some studies have shown good results with this ORIF alone approach in specific patient groups. However, it's critically important to acknowledge that other studies have reported higher non-union rates when ORIF is used for B2 fractures, especially if the underlying instability isn't fully accounted for. It's a calculated risk. And as I mentioned earlier, for very frail, inoperable patients with minimally displaced B2 fractures, anabolic agents might even be considered for conservative management, particularly around these specific cemented stems. The key is truly individualized decision-making based on the whole picture.
So while revision arthroplasty is the undeniable gold standard for B2s, there are indeed specific, highly selected scenarios where ORF can be a viable, less invasive alternative. What happens then with subtype B3 fractures, where you're dealing with both an unstable prosthesis and a severe, inadequate bone stock? This sounds incredibly challenging, almost like trying to build on sand.
You've hit the nail on the head. Subtype B3 fractures are exceptionally challenging, precisely because of that combination: a loose prosthesis and massive bone deficiency. It is indeed often like building on crumbling ruins.
A real reconstructive nightmare.
It can be.
Yeah.
The primary treatment options typically involve major femoral component revision, often requiring techniques like using a proximal femoral allograft that's cadaver bone,
Right.
or even a proximal femoral replacement, where you replace the whole top end of the femur with metal. Impaction grafting, where morselized bone graft is tightly packed into defects, can also be used effectively for large, contained bone defects, essentially rebuilding the foundation. Surgeons have an array of specialized implants available for these complex reconstructions: fully porous-coated stems, tapered fluted stems, modular or monoblock designs, distally locking stems, and as I said, dedicated proximal femoral replacement prostheses.
Lots of options, but complex ones.
Very complex. The key here isn't just having these implants, but surgeon familiarity with the chosen system and the ability to apply a reproducible, meticulous surgical technique, often refined over many years. Achieving adequate distal stem stability in the diaphyseal bone is paramount. Sometimes it's the only healthy bone available for fixation. Meticulous preoperative templating, along with careful intraoperative assessment of leg length and overall stability, is crucial to prevent postoperative issues. It's also vital to preserve as much proximal metaphyseal bone as possible, even if it's fractured, and to wrap the remaining femur with its soft tissue attachments around the new prosthesis. This provides biological stability and optimizes muscle function.
Trying to salvage everything you can.
Absolutely. Allograft prosthetic composites, which combine a cadaveric bone segment and allograft with a new prosthesis, can be invaluable for massive bone loss, particularly in younger patients where long-term durability and bone stock restoration are priorities. These can be used with uncemented, cemented, or partially cemented techniques, depending on the specific case. And finally, for older patients with severe bone deficiency or very poor prognosis, a proximal femoral replacement, despite a relatively high complication rate and the sheer magnitude of the surgery, can sometimes be the only viable option to get them mobilized.
A last resort in some ways.
In some ways, yes. These B3 cases, they're often the ones that truly test a surgeon's mettle, not just technically, but in terms of resourcefulness and judgment. You have to be prepared for almost anything, knowing you might be trying to build a stable foundation on what often feels like crumbling ruins.
It's clear that B3s demand an extraordinary level of reconstructive surgery and planning. Now, moving away from the area immediately around the stem, what about Vancouver type C fractures, which occur well below the implant tip? How do these differ in their management strategy?
Right. Vancouver type C fractures are distinct because they are located in the distal third of the femur, well below the femoral stem. Typically more than 2 to 3 times the femoral diameter distal to the implant tip. Critically, these fractures do not compromise the stability of the hip prosthesis itself, which remains well fixed proximally.
So the hip joint part is okay.
Exactly. Therefore, the primary treatment involves open reduction and internal fixation, using standard osteosynthesis techniques, mostly bridge plating or, less commonly, retrograde nailing from the knee end. The key principle here is that while the hip prosthesis itself is stable, its presence in the proximal femur must be accounted for to minimize the risk of secondary fractures or stress risers forming between the hip stem and the new fixation distally.
Avoiding a weak spot in the middle.
Precisely. Even if a short plate might appear biomechanically adequate for the immediate fracture, the contemporary consensus born out of experience is to protect the entire diaphysis by overlapping the femoral component proximally. Anchoring proximally with Kirklush cables or screws around or past the tip of the stem, this approach ensures a better balance of the construct's working length, plate span width, and screw ratio, distributing stresses more evenly across the bone. More importantly, it provides crucial protection against future injuries.
You're thinking ahead again.
Yes, as these patients are highly susceptible to subsequent falls that could easily lead to new fractures if parts of the diaphysis are left unprotected, creating a new stress riser at the end of a short plate. Therefore, most surgeons now prefer to span the whole femur with a long retrograde locking plate, ensuring maximum fixation at the distal metaphysis and a combination of screws and cables proximally. This is about preventing the next fracture, not just fixing the current one.
So we've taken a deep dive into femoral periprosthetic fractures, which are undoubtedly the most common and challenging. But what about those equally demanding, albeit less frequent, fractures involving multiple implants, known as interprosthetic femoral fractures, or those affecting the acetabulum? Let's start with interprosthetic femoral fractures.
Right. Interprosthetic femoral fractures, or IFFs. These are defined as fractures occurring between an ipsilateral hip and knee implant.
So a hip replacement and a knee replacement on the same leg.
Exactly. And the fracture happens in the femur shaft between those two prostheses. While still relatively uncommon, they represent a growing challenge in our practice. They account for about 5% to 7% of all periprosthetic femoral fractures, and their incidence will certainly rise as more patients receive both implants.
Makes sense.
Classification is absolutely key here to guide treatment. Pyers et al.'s 2014 classification is considered the most comprehensive. It strategically divides IFFs into 3 major categories based on the fracture location, the stability of both the hip and knee implants, and importantly, whether there's a stemmed knee femoral component, as this significantly impacts reconstructive options. This system then provides a guiding treatment algorithm based on these variables.
So it considers both ends.
Precisely. For management, if both the hip and knee implants are stable, then fracture fixation is the primary approach, with locking plates being the implant of choice due to their versatility and fixed angle stability. However, if either the hip or knee implant, or both, are unstable, then revision arthroplasty of the unstable component is necessary, often supplemented by internal fixation to stabilize the fracture itself.
Right. Address the loose bit first.
You have to. For complex or severe cases, especially those with significant comminution or bone loss, various composite constructs, including intramedullary options where a rod is placed inside the bone and strut grafting, can provide both intra- and extramedullary stability. A critical surgical principle, regardless of the chosen strategy, is to bypass the fracture adequately, avoid creating new stress risers at the ends of implants, and ideally span the entire femur between the two prostheses, or at least overlap the prosthesis by at least 2 cortical diameters beyond the fracture. In the most severe cases, particularly certain Pyers types, especially with poor bone stock, options can include advanced arthroplasty with adjuvant fixation or even total femur replacement. That's a truly massive reconstructive procedure.
Replacing the whole thigh bone.
Essentially, yes. The outcomes for IFFs can be quite challenging, reflecting the complexity of these injuries and the often frail patient population. Reported non-union rates are around 8%, with mortality rates around 6.5%, and revision rates for failure at about 10.7%. However, it's worth noting that some studies, such as Bonvial et al.'s series, have reported significantly higher mortality rates, up to 31%, and revision rates of 24%.
31% mortality, that's very high.
It is sobering. These statistics truly underscore the fragile nature of this patient cohort and the absolute necessity for meticulous planning and execution to avoid catastrophic failures.
Those mortality rates are indeed sobering, highlighting the severe challenge these fractures pose. Now, turning our attention to the acetabulum, the socket side. Periprosthetic acetabular fractures are less common, but I imagine equally, if not more, severe and challenging to treat. What are the unique aspects of these injuries?
Absolutely. Periprosthetic acetabular fractures, while less common than the femoral ones, present profound challenges to the surgeon. Their incidence is also expected to rise with the increasing numbers of elderly and more active individuals undergoing THA. These fractures can occur either intraoperatively during the primary or revision surgery or postoperatively. Intraoperatively, they are most frequently associated with uncemented press-fit elliptical cups.
The uncemented cups again.
Yes, where the force of insertion can cause microfractures or larger breaks. They're also more common during revision THRs than primary ones, often due to a combination of patient factors like severe osteoporosis and surgeon-related technical challenges in working with altered anatomy or removing old components. Postoperatively, they can result from high-energy trauma or, more commonly, from severe bone loss due to underlying conditions like osteoporosis, aseptic loosening of the implant, osteolysis, pelvic discontinuity, we will discuss in a moment, malignancy, or infection.
So similar underlying causes to femoral fracture sometimes.
Similar risk factors, yes, but manifesting in the pelvis. For classification, the Periprosthetic system is commonly used, describing various types based on the extent and location of bone loss and fracture patterns. Pasquarella et al. Have also presented a comprehensive system that guides surgical planning based on the timing of diagnosis, the stability of the acetabular prosthesis, and the pre-injury arthroplasty state. Diagnosis requires a highly comprehensive approach to identify and precisely classify the fracture and, crucially, determine the stability of the implant. Intraoperative fluoroscopy can be immensely useful to confirm reduction and fixation during surgery. Postoperatively, patients typically present with significant pain, loss of function, reduced range of motion, inability to weight bear, or a leg length discrepancy. In acute traumatic injuries, there's even a potential for life-threatening hemorrhage due to the rich vascularity of the pelvis.
Bleeding is a major risk there.
A very significant risk. Imaging includes plain radiographs, standard AP pelvis, Judith views which highlight specific pelvic columns, and inlet-outlet views and CT scans with 3D reconstruction. These are essential to provide detailed information on the fracture pattern, the extent of bone loss, and the relationship of the implant to the bone. In cases of severe displacement, CT angiography may even be recommended to rule out potential vascular injuries.
So once diagnosed, what are the core treatment principles for these acetabular fractures, especially given the complexities of bone stock and component stability? It sounds like a delicate balance between fixation and revision.
That's precisely the challenge. The fundamental treatment principles for periprosthetic acetabular fractures revolve around achieving a stable acetabulum that can adequately support the component, preventing any micromotion at the implant-bone interface. This almost always necessitates adequate bone stock, with or without additional augmentation, to ensure secure implantation and long-term stability. For intraoperatively identified fractures, if they are undisplaced and the cup is stable, they can sometimes be left in situ with standard rehabilitation. But supplemented screw fixation of the cup is generally recommended to provide additional stability and reduce the risk of secondary displacement.
Add a few screws for safety.
Usually a good idea. If the cup is unstable and there's fracture displacement, the meticulous open reduction and posterior column plating, followed by the insertion of a revision cup, is advised. For missed intraoperative fractures, which can happen, close follow-up with serial radiographs is critical to monitor for any delayed displacement or cup migration, which would then necessitate revision surgery.
Keep a close eye on them.
Definitely. For postoperative fractures, acute, traumatic, undisplaced fractures with a stable cup may initially be treated conservatively with protected weight bearing and gentle mobilization. However, close follow-up with serial radiographs is mandatory due to the insidious risk of secondary loosening, even if the fracture appears to heal.
So even if it looks okay initially.
It can loosen later. If that occurs, revision surgery over consolidated bone may be needed. However, if the fracture fails to heal, or if there's an unstable fracture pattern with an unstable component, then prompt ORF, most often posterior column fixation combined with revision surgery, is unequivocally required.
And what about pelvic discontinuity, which sounds particularly severe? Can you elaborate on what that is and how it's approached?
Pelvic discontinuity, or PD, is indeed a particularly challenging condition. Imagine the acetabulum, the socket of the hip joint, actually detaching or splitting from the rest of the pelvis, essentially losing its structural integrity in both the anterior and posterior columns.
The whole socket breaks away.
Effectively, yes. It's a catastrophic failure of the bone that normally supports the hip cup, making reconstruction incredibly complex because you're trying to reestablish a stable ring from what is now two separate fragments. Treatment for PD is highly individualized, factoring in bone quality and quantity, the soft tissue environment, and the patient's overall health and functional demands. Rogers et al. Proposed a useful algorithm distinguishing between acute and chronic discontinuity. Acute, mobile discontinuities are typically treated with ORAF and revision surgery, aiming to anatomically reduce and fix the fracture while simultaneously revising the unstable cup. Chronic, more rigid discontinuities, where the fragments have healed in a malunited or non-united position, often require a more extensive approach, commonly a cup cage reconstruction.
Cage.
What's that? It's essentially a Mel construct, often made of titanium, that bridges the gap between the separated pelvic fragments and provides a stable platform to cement or fix a new cup into. It bypasses the deficient bone. Other options for managing pelvic discontinuity include the use of robust column plates to bridge the defect, structural grafting to fill bone voids, anti-protrusio cages to prevent the cup from migrating inwards into the pelvis, or jumbo cups, often combined with porous trabecular metal augments, particularly for cases with good healing potential and minor bone loss. For chronic cases with little inherent support and poor avascular bone, distraction techniques like a cup cage are often invaluable. They literally bridge the gap, allowing bone to potentially heal around them and create a new stable bridge. In situations of truly massive bone loss, a triflange component, which is a custom-made implant based on the patient's CT scan, is typically required. It essentially rebuilds the complex pelvic anatomy with metal flanges that fix to remaining healthy bone.
Custom-made implants. Very complex.
Extremely complex. Other techniques might include impaction grafting, non-cemented hemispherical reconstruction, structural allografts, though largely superseded by porous metal augments, now oblong cups, or other cages like Gans and Bert Schneider, or the Kerbal Tanaka plate. The key is selecting the technique that best reestablishes the structural integrity of the acetabulum and allows for secure, long-term cup fixation.
We've covered a remarkable amount of ground on the clinical management and the sheer technical complexity. So what does this all mean for the patient in the long run? Given these complexities, what are the typical outcomes? And crucially, what are we doing as a field to prevent these fractures in the first place? And what does the future hold for orthopedic practice in this area?
Right, the overall outcomes and complications for periprosthetic hip fractures really highlight their significant impact on patients' lives. In the acute phase, these fractures carry a mortality risk comparable to that of native neck of femur fractures in the elderly.
Same mortality as a standard hip fracture.
Initially, yes, which is a stark comparison. We see a one-year mortality rate reported at around 9.7%. This risk does seem to decrease significantly after the initial 6 months post-surgery, which suggests that critical early period is key. The overall 30-day complication rate is notably high at 45%, with a concerning 22% being major complications and 13% minor, and a 30-day mortality rate of 10%.
10% mortality in 30 days.
Yes. It's critical to note that significant risk factors for these adverse outcomes include a patient's abbreviated mental test score, or AMTS, of 8 out of 10 or less, indicating some level of cognitive impairment, and a delay to surgery of more than 72 hours.
So cognition and timing matter hugely.
Absolutely. This underscores the need for rapid assessment and intervention, as well as comprehensive geriatric co-management. Functional and radiological outcome data are somewhat limited, largely due to the wide diversity of fracture types, the varied treatment approaches, and the high morbidity and mortality rates inherent in this patient population, not to mention characteristics like those low AMTS scores. However, studies generally indicate that patients undergoing revision for periprosthetic fractures tend to have worse functional outcomes compared to those revised simply for aseptic THA loosening.
Worse function than a standard revision.
Generally, yes. Functional impairment is common, with studies showing around 41.9% of patients may not return to their pre-injury walking status. That's a truly significant impact on their quality of life. The most unfavorable prognosis in terms of both survival and functional return is typically seen after a B3 fracture, given the extent of bone loss and surgical complexity involved. As for arthroplasty longevity after these revisions, long-term data are rather sparse due to the high mortality and restricted follow-up in this frail cohort. Though short to mid-term studies generally report high union rates and stable implants, we need more long-term data.
Beyond the immediate outcomes, infection is always a major concern in orthopedic surgery, and I imagine periprosthetic joint infection, or PJI, is a critical and potentially devastating complication here. What's the situation with PJIs in this context?
PJI is indeed a critical complication, and its incidence is unfortunately rising in parallel with the increasing number of arthroplasty procedures globally. This leads to significant morbidity and mortality, and the cost of treatment is truly substantial, particularly in regions with limited health insurance access.
It's a huge burden.
A massive burden. Effective management demands a high level of teamwork, involving a dedicated multidisciplinary team. That includes microbiologists, histobiologists, pathophysiologists, working alongside orthopedic surgeons, often guided by clear radiological imaging and comprehensive laboratory results. Diagnosis relies on a combination of strong clinical evidence and, crucially, identifying the causative organism. Preoperative testing typically includes hematological markers such as ESR and CRP, advanced imaging like X-rays, maybe PD scans, and synovial fluid analysis looking at cell counts, leukocyte esterase, and most importantly, cultures. However, intraoperative tissue samples taken from multiple sites within the joint during surgery are vital for definitive diagnosis and identifying the specific pathogen. Newer methods such as PCR are also becoming more available, offering quicker and potentially more sensitive detection.
Getting the right bug is key.
Absolutely essential for targeted treatment. The treatment algorithm for PJI is complex. For acute infections occurring soon after surgery, debridement, antibiotics, and implant retention, or DARE, is often considered. However, for infections older than 3 weeks, where biofilms have likely established on the implant surface, a multi-stage approach, often guided by algorithms like Zimmerle's, may be necessary.
Biofilms make it much harder.
Much harder. In some severe intractable cases, a salvage operation, like arthrodesis, fusion of the joint, or even amputation, might be the only option left. The most common choice among surgeons, and generally considered the gold standard for chronic PJI, is a 2-stage exchange.
2 stages? How does that work?
The first stage involves complete removal of the implant, thorough debridement of all infected and devitalized tissue, and temporary installation of an antibiotic-impregnated cement spacer into the joint space.
A spacer with antibiotics.
Yes, delivering high local concentrations. After an interim waiting period, typically 2 to 6 weeks or even longer, allowing systemic antibiotics to take effect and infection markers to normalize. The second stage involves implanting a new prosthesis and taking further tissue biopsies to confirm infection eradication. Patients usually receive a prolonged course of oral antibiotics, often for 6 weeks or more, following the second stage. It's also important to consider special patient conditions, like immunosuppression or cognitive decline, and country-specific challenges, such as delayed presentation due to financial constraints or limited access to certain antibiotics in developing nations, all of which complicate effective management.
That's a comprehensive yet daunting approach to managing a potentially devastating complication. Given all these challenges, what proactive prevention strategies are being implemented? And what does the future hold for this field?
Prevention is absolutely crucial for patient success and to mitigate the rising burden of these fractures. It starts long before surgery and continues long after. Patient education, for instance, isn't just handing them a leaflet. It's a deep dive into realistic expectations, the absolute necessity of compliance with rehabilitation protocols, and a clear understanding of their physical limitations and risks. We often involve physical therapists in preoperative counseling to design personalized home exercise programs, emphasizing not just strength, but balance and proprioception to prevent falls.
Preventing the falls in the first place.
Exactly. And it's not just about what they do after surgery. It's about optimizing their overall bone health, now ensuring adequate calcium and vitamin D intake, maybe even considering anti-osteoporotic medications like bisphosphonates or teriparatide if indicated. We also stress environmental modifications, simple but critical things like securing rugs, improving home lighting, installing grab bars in bathrooms. It's a holistic approach to fall prevention, recognizing that one bad fall can undo all the surgical success.
Simple things can make a big difference.
They really can. Preoperative assessments are also essential to identify high-risk patients, those with atypical anatomy, significant fixed deformities, or leg length discrepancies, allowing us to tailor prophylactic measures or choose specific implant designs to minimize risk. During surgery, meticulous implant positioning and fixation, maintaining an impeccably sterile environment, and early controlled mobilization are key to reducing postoperative complications. Looking to the future, the evolution of orthopedic implants continues at a rapid pace, providing more surgical options. However, there's a clear and ongoing need for even more specially designed implants that can better address the vast majority of periprosthetic fractures, particularly those with complex geometry and significant bone loss.
Better tools for the job.
Exactly. New concepts in fracture fixation, such as plates with far cortical locking, which offer unique biomechanical advantages by engaging the opposite cortex, and active plating, where the plate itself provides dynamic compression, are emerging. These will require robust clinical evidence and long-term studies to thoroughly evaluate their outcomes in practice. A significant remaining challenge is the limited robust data on long-term functional outcomes and implant longevity following revision surgery for periprosthetic fractures. This is critical, especially as their incidence is projected to continue rising. Interprosthetic and periprosthetic acetabular fractures, while currently less common, represent growing challenges that demand further dedicated research and evidence-based guidelines. Ultimately, the substantial financial burden these complex injuries place on healthcare systems globally highlights an ongoing and pressing need for more effective, predictable solutions, and perhaps a potential move toward specialized regional centers to provide optimal, cost-effective care for these highly complex cases.
So, what does this all mean for us as medical professionals? The management of periprosthetic hip fractures remains one of the most complex and critical areas in orthopedic surgery today. It's abundantly clear that successful outcomes hinge on a deeply individualized approach, one that seamlessly combines highly advanced surgical skills with comprehensive patient assessment, rigorous risk stratification, and meticulous postoperative care. As the number of total hip arthroplasties continues to rise globally, so too will the incidence of these challenging fractures, meaning this will remain a focal point for decades to come. The ongoing need for innovation in implant design, refined surgical techniques, and robust long-term data for our decision-making simply cannot be overstated. If you found this deep dive valuable, please do take a moment to rate and share this deep dive with a colleague who might benefit. Join us next time on the deep dive as we continue to explore the cutting edge of medical knowledge.
This raises an important overarching question for all of us in the field, doesn't it? How can we further collaborate across disciplines and national borders to standardize best practices, share learnings, reduce complications, and ultimately improve not just survival, but the meaningful quality of life for this increasingly frail and complex patient population? The journey of mastering periprosthetic fracture management is an ongoing one, a continuous learning curve for us all.